An enlightening talk on the past, present, and future of insulin. Uh, we now move on to the next session for the day, which is the Sushil Kumar Banerjee Memorial Session. It is in memory of Sushil Kumar Banerjee, who passed away in 1998 of diabetes, and his wife and daughter also lost their lives to diabetes. So, this is in memory of Mr. Sushil Kumar Banerjee. To chair this session, I would like to welcome Professor Sujoy Ghosh sir and Dr. Anirban Majumdar sir. I welcome you both, sir, and over to you. Please take over the session.
Thank you very much, organizers, for having given me and also my co-chairperson, Professor Anirban Majumdar, an opportunity to chair this session. And it would be my privilege to both introduce the speaker as well as the topic. And today being Insulin Discovery Day, in keeping with the theme of insulin, we are going to talk about the use of insulin in critical care setting. And because of what we have been going through over the last a year and a half, and which we anticipate we will have to deal with again for the next year or so at least, COVID-19, we would be talking about insulin in critical care setting with special reference to COVID-19, and the speaker is none other than Dr. Sambit Das. If I could have Sambit's intro slide. Sambit is Professor of Endocrinology at High Tech Medical College, Bhubaneswar, and he's been an ex-student of PGI Chandigarh, from where he's done his DM, his FACE, and he has published several papers in international and national journals. He's been the PI of several phase 3 clinical trials. I myself am fortunate that he is part of the EC of the Endocrine Society of India, and he's been on the editorial board of several journals and is the secretary of the Endocrine Society of Odisha and is secretary of the Obesity Society of Odisha chapter as well. He's been the scientific secretary of ESICON Obesity and has won the Inspiring Endocrinologist Award 2019 and the Times Health Icon Award 2016. More importantly, Sambit is very close to us and a very close friend of ours. Sambit, the screen is all yours.
Thank you, Sujay sir, for that kind introduction. Let me first share my slide. My slides are visible?
Yes, they are, and you are audible.
Yeah. Thank you. So a very good evening, everyone. And at the outset,
if you could just make it full screen, Sambit.
Sambit. Yeah. I'll share it. Is it full screen now?
Excellent. Excellent.
Yes, yeah. So, a very good evening, one all, and at the outset, I must thank the Diabetes Association of West Bengal for giving this opportunity, and special thanks to Sujay sir and Anirban sir. So, I'll be talking on insulin in critical care setting and special reference to COVID-19. And obviously, we are passing through this pandemic, so I'll just discuss about COVID-19 and the criticality in diabetes and how the COVID-19 can be critical and admitted in ICU setup, and then I will discuss how we can go about managing these patients. So this is just to highlight the bidirectional relationship between diabetes and COVID-19, and that we know way back in 2020 with the first wave only, where diabetes leads to poor innate immunity, leads to pro-inflammatory cytokines, and downregulates the ACE2 pathways, and which is detrimental for this virus. And COVID-19 in turn may produce some problem, like it may lead to beta cell damage that may lead to new onset diabetes with COVID-19 or COVID-induced diabetes. And then there are insulin resistance and cytokines and between A, and there occurs, or we use some of the drugs like corticosteroid that may hamper the glycemic control, and they may lead to steroid associated hyperglycemia. So this is how both the things are interrelated, and both can lead to problems. So just to highlight that COVID-19, if we compare the patients with diabetes versus patients who are not having diabetes, then there is more chances of critical care management or ICU admission in patients who have diabetes in comparison to patients who do not have diabetes. And 58% of COVID-19 patients admitted to ICU have diabetes. And hospital admission and critical illness was higher for people who are having diabetes. Now we all know these facts. The pre-existing diabetes was associated with 2 times higher risk of having severe critical COVID-19 illness, and it also increases the mortality. So the mortality is almost increased by 3 times in patients with diabetes in comparison to those who do not have diabetes. And this is a meta-analysis of 83 observational studies. Now, is the reverse also true? If we are controlling the blood glucose stringently in the hospitalized patient, are we going to save more number of patients? I think the answer is yes. And we have this retrospective multi-center study with 7,300 COVID-19 patients with or without diabetes, and where it was found that there is definite survival benefit in patients who are controlled or the glycemic status is well controlled in comparison to patients who have poorly controlled diabetes during the in-hospital stay. So there is 10 times lower in-hospital mortality, 1.1 versus 11% in patients with well-controlled blood glucose versus poor blood glucose control, that is more than 180 milligram per deciliter. So good glycemic control improves clinical outcome in COVID-19 hospitalized patients. So this is just to highlight the ICMR and National Task Force, the recommendation which was published in 22nd April, where they have divided the COVID-19 patients according to the severity as mild, moderate, and severe disease. Since we are talking about the critical illness, so mostly deals with severe disease or moderate disease. So anyone having respiratory rate more than 24 with saturation between 90 to 93% in room air, or severe disease where the respiratory rate is more than 30 with saturation less than 90% in the room air. And these are the risk factor. Among them, diabetes is one of the major risk factor. And all these severe patients need to be admitted in ICU, or at least the recommendation goes like that. And they need respiratory support. Apart from that, they need some anti-inflammatory and immunomodulatory therapy like corticosteroid, which are high in dose. Like we need to give methylprednisolone 1 to 2 milligram per kg IV in 2 divided doses or equivalent doses of dexamethasone, usually for a duration of 5 to 10 days. So that is the recommendation by the ICMR. And for that reason, all the critical patients who are having severe COVID-19 need to be admitted to a COVID ICU. Now, I actually gathered, when I got this talk, I actually gathered some of the information from the intensivists who are managing the COVID ICU and who were also managing the non-COVID ICUs beforehand. So this is a perspective from intensivists, and mostly all the COVID ICU, at least I know in my state, are managed by intensivists. And they have a common problem that they were telling nutritional status is a big problem over there. Like all the patients, even if they're stable, and are on NIV and who can take feed, but they are usually not remove that NIV for food, and they are giving active-feed or liquid diet in terms of straw. So that's one of the reason. Now, two important evidences which are definitely good for COVID-19 critical patient. One is steroids, and that poses a huge challenge in terms of glycemic control for them. Third is the proning in ICU, and that's also recommended, and almost 16 to 17 hours they have to be in prone condition, and that leads to more of regurgitation, and the nutrition becomes still poorer when they are on RT feeding. So these are the three things what they told in terms of glycemic fluctuation and problems in glycemic management. Lack of consultation with an endocrine team or a diabetologist team is always there, even in bigger setup, because always the communication is through the phone, and sometimes it causes difficulty unless there is a clear cut guideline. Monitoring difficulties is always there because they have been dealing with a poor number of staffs and less experienced staff at the peak of the COVID time. So monitoring of insulin infusion every hourly sometimes is a problem. And so their perspective, what they want from the endocrinologist is we need to simplify the insulin regimen in all possible routes so that it can be nurses driven or at least the intensivist driven. And these are the people who can manage the glycemic control in the ICU setup. So hyperglycemia in critical COVID-19 patients can be of four types. One is either they may have pre-existing diabetes that is aggravated, or there is a poor glycemic control. It can be a stress hyperglycemia, or it can be a COVID-induced diabetes that leads to beta cell dysfunction and hyperglycemia. Fourth is COVID treatment related hyperglycemia, and that is because of the use of high doses of steroid. And many times they may land up in hyperglycemic emergencies like HHS and decay also. So stress hyperglycemia versus non-diabetes, the complication and the mortality we all know from the previous studies also in 2005, where you can see that the patient's hyperglycemia in patients without diabetes, that is stress hyperglycemia denoted in this purple column, the mortality is in fact more in comparison to patients who have diabetes and poor glycemic control. So stress hyperglycemia is a challenge, and that's a major problem in COVID-19 ICU setup also. The second problem is steroids, and we know that steroid has to be used in high doses, and people should know the potency and the half-life of different steroids that has been used. Just to highlight how steroid can produce hyperglycemia, there are so many pathways, but simplistically speaking, it is basically the increased gluconeogenesis from the liver, in the peripheral insulin resistance in the muscle level, and more amount of gluconeogenic precursors that has been produced by lipolysis from the fat or by proteolysis from the muscles. So all can lead to more amount of glucose production and hyperglycemia due to steroids. COVID-19 patients can land up in emergencies with decay or HHS, and there is a nice study where they have compared patients who have been admitted with decay who are having COVID-19 versus who do not have COVID-19. And when they compared the hospital stay, the mortality and the morbidity, it was found that these patients who are COVID-19 positive have very high insulin requirement. They have longer duration of insulin treatment, longer time of decay resolution also, 9.9 hours versus 7.1 hours, and they have higher acute renal insufficiency, and the mortality was also higher. In hospital death was also more in COVID-19 decay comparison to non-COVID-19 decay patients. Now the next question is whether we should control the blood glucose tightly in ICU or in critical care COVID-19 patients or not. There are so many data beforehand about the good glycemic control leading to better outcome in the ICU setup. And then there is nice sugar way back in maybe in 2009 that told that in a large cohort of patients of 6,100 patients, when tight glycemic control was achieved to the tune of 81 to 108, the mortality was in fact higher in comparison to when the blood glucose was kept at less than 180. So from there, and then there was a meta-analysis where tight control versus non-tight control were compared, and they found that there was no significant difference in mortality. The risk of septicemia was numerically lower, but the chances of hypoglycemia was significantly higher. And for that reason, you can see the forest plot, the hypoglycemia is significantly higher, whereas the mortality benefit and septicemia are nearly equal in tight versus non-tight control. So for that, till now, we follow the same guideline what has been postulated in AACE in 2009, that in the ICU setup, insulin infusion should be used to control the hyperglycemia. The starting threshold should be 180 milligram per deciliter. And once IV insulin is started, the glucose levels should be maintained between 140 to 180 milligram per deciliter. We can go down to 110 to 140 milligram per deciliter, provided we have well-experienced staff, we have a good experience, and the patients are maybe post-CABG patients and all. But ideally, we can keep it between 140 to 180. ADA 2021 goes even one step further, telling that when there are severe comorbidities or in patient care setting where frequent blood glucose or close nursing supervision is not feasible, maybe higher glucose range can be kept around 200 milligram per deciliter. I think in our setup where the ICUs were challenged with COVID-19, we can keep a little bit looser control also, but ideally we can target a 140 to 180 milligram per deciliter. Now, what should be used in ICU? It's nothing but insulin, nothing we can use for glycemic control other than insulin. It is the most powerful agent we have to control blood glucose. What are the types of insulin therapy in critical care? Insulin infusion is the gold standard. Almost all the guidelines have recommended that. Basal bolus, only very select condition where we want to shift the patient who are very stable to oral intake and then to basal bolus or then to the step down SDU or into the ward. Premix insulin has got very limited role. Ideally, we should not be using. One message is that sliding scale insulin therapy should not be used in critical care or not in any hospitalized setup. These are the snapshot of various guidelines for ICU management of hyperglycemia in critical care setup, and almost all the guidelines agree that the target should be between 140 to 180 milligram per deciliter, and the initiation of blood insulin infusion should be started at the threshold of 180 milligram per deciliter. And all these guidelines have also endorsed that insulin infusion therapy with a regular insulin is the standard therapy, and we should start and titrate with this insulin infusion therapy. The indications for insulin infusion in COVID-19, even if they are not in ICU setup, is that any patients who presents with hyperglycemic emergencies like decay and HHS, that's obvious, we have to start on insulin infusion. Severe hypoglycemia, more than 300 to 400 milligram preprandial or post-meal values need insulin infusion. Critically ill patients with sepsis on inotropes on ventilators, insulin infusion is a must. We should have a low threshold for starting an insulin infusion, and that cutoff also we have put as 180 milligram per deciliter. Uncontrolled hyperglycemia, despite the appropriate use of basal-bolus insulin regimen, especially when patients are on high doses of steroid, their insulin infusion is good. Patients with erratic diet and frequent vomiting and in ICU, again insulin infusion is a must. So IV insulin infusion is the preferred modality of insulin delivery in patients who are admitted to critical care in COVID-19. IV insulin protocol, there are n number of protocols which are currently available. Basically, whatever large RCTs they have done, they have formulated their own protocol. But these are some of the famous protocols which are being adopted. And this is a snapshot of all the protocols and their pros and cons and how what is their target and how to initiate. I'm not going into details of that. But the most important thing is that whatever protocol you adopt, it has to be an institutional protocol. That means in that given hospital, it has adopted that protocol. It has to be simple to use, as our intensivist told, that it has to be a paper driven and it should be very simple to use because mostly the nursing staff will be using that. Bedside availability is a must. It should be nurses driven, and periodic validation and review of effectiveness should be done by the treating team. Initiating an insulin infusion in ICU, and it's simple. We start, we form a solution of around 1 unit of short-acting insulin with 1 ml of normal saline. So in that strength, we prepare a solution, preferably administered by infusion pump, and in ICU, we get the infusion pump in abundance. But if we don't get, maybe a pediatric infusion set we can use. Priming is important, and all should know that at least we can flush 20 to 50 ml of infusion through all IV tubing before insulin therapy or the intravenous insulin therapy begins to saturate the insulin binding sites in the tubing. Unused insulin has to be discarded within 24 hours. We should not be putting that insulin for more than 24 hours once it is prepared. Initiation, we can use any protocol, but the conventional on the easiest way to start is probably the modified Yale phenom protocol, where a simple formula to calculate is we can divide the CBG by 100 or the capillary blood glucose by 100, or it can be initiated by 0.05 to 0.1 units per kg per hour. So if a person is having 300 milligram per deciliter, we can just start with 300 by 100, that is 3 ml per hour or 3 units per hour. Infusion rate and titration, insulin infusion titration depends on various factors. That is, what is the existing blood glucose level, magnitude of blood glucose changes in the previous hour, desired blood glucose target, and expected intake of major or minor meals. And the initial target fall should be 50 to 75 milligram per deciliter. If it is less than 50, we need to up titrate the insulin infusion. If it is less than 50, we need to down titrate. If it is more than 75, we need to up titrate the insulin infusion. Again, there are some easy method of insulin infusion titration, and it's also from the Yale's protocol. It's quite easy, can be used. But one of the simplest titration algorithm I could get from the consensus recommendation by Dr. J.J. Mukherjee et al., which was published in 2015 in JAPI. They've formulated a blood glucose and how the insulin should be titrated. So that's a easy formulation, and that can be kept in the ICU at the bedside, and the sister can follow it. An institutional protocol for management of hypoglycemia is also should be in place, so that the sister can easily intervene at the earliest time. One of the protocol that can be given is that if we are giving an insulin, if the blood glucose is going less than 100, we can hold the insulin, observe and check the blood glucose every 30 minutes till it is more than 100. And once it is more than 180, we can restart the insulin infusion at half the rate. If there is hypoglycemia, we can hold the insulin, we can check it more frequently, maybe 15 to 30 minutes, we can give IV dextrose solution, and we try to maintain the blood glucose above 100. Once it is more than 180, we can start with a lesser rate. So that has to be very clear cut written and should be placed in the ICU. Blood glucose monitoring in ICU, I think check blood glucose hourly is the recommendation, and if the 3 consecutive values are within the target, we can relax the blood glucose monitoring to every 2 hourly. And blood glucose check can be spaced every 4 hourly if there is no significant change in the clinical condition and there is no significant change in the nutritional intake. Consider resumption of hourly blood glucose monitoring if any of the following condition arises, like any change in the insulin infusion, or significant change in the clinical condition, or if steroid therapy has been hiked up or lowered down, or initiation of cessation of renal replacement therapy, or any nutritional support has been changed. Role of CGMS, I think we talk a lot about the continuous glucose monitoring, but the evidence are less in ICU setup because of many factors. But in US FDA, they have approved 2 CGM which can monitor the venous blood, and that is Glucose Scout and OptiScanner 5000 Pro. I'm not sure whether it will be ever available in India, but these are the 2 CGMS which can be used in patients with in ICU setup. But there are concerns that data is lacking. Accuracy of continuous glucose monitoring data with acute physiological disturbances is doubtful, like hypoxemia, vasoconstriction, severe dehydration. Chemical interference with glucose reading like paracetamol, salicylic acid, and ascorbic acid. So all these factors may interfere with the CGM reading. But currently, I think CGM use in critical setup is difficult. Now switching from insulin infusion to basal-bolus insulin infusion, blood glucose level are controlled on insulin infusion, patient on orally accepting or on RT feed, hemodynamically stable, we can try for changing. And insulin infusion should not be stopped abruptly, and there should be overlap of at least 1 hour with the subcutaneous insulin. We can calculate the total daily dose based on the insulin infusion requirement in the last 24 hours. And we can extrapolate the last 4 hours when the blood glucose is stable and the infusion is stable, and to the 24-hour. 50% of the total daily dose can be given as bolus, and rest 50 can be divided into 50% can be given as 3 divided bolus, or 50% can be given as basal. But in those patients who are steroids, and mostly our patients who are COVID are on steroids, then it may be necessary to change the ratio to 30% as basal and 70% as bolus. So maybe more bolus requirement is there, and mostly it is during the lunch time or maybe in the evening snack time if the patient is taking orally properly. Use of only sliding scale regimen is absolutely contraindicated. Which basal insulin to use? Last few slides, like basal insulin like glargine, degludec, U300 can be used as part of the basal bolus regimen, and there are evidences of in-hospital management of this basal insulin also. But in COVID-19, especially those who are on steroid, I think many recommendation goes with the NPH insulin, and old is gold in that condition. Like if someone is getting a once daily the steroid, then probably an NPH insulin in the morning time is a better option. But we can use the NPH twice a day with 2/3 in the morning and 1/3 in the evening when we are giving high doses of long-acting steroids or multiple doses of steroids. Which bolus to use? I think it was very nicely discussed by Hari sir that what about analogs versus the regular human insulin? I think analogs are better in term that it adds to the flexibility, and probably the late postprandial hypoglycemia is relatively lower. But in terms of reduction of the HbA1c, I think there is no robust data that analogs have better A1C reduction in comparison to regular human insulin. So with that, I'll conclude. I think we have discussed about the critical condition of COVID and how hyperglycemia is a big thing in increasing the morbidity and mortality. Good glycemic control without hypoglycemia should be our target. IV insulin therapy is the gold standard. Sliding scale should be discarded. IV insulin therapy, once it is stabilized, the patient can be switched over to a basal-bolus therapy. Institutional protocol and an easy protocol which can be driven by the nurses is the need of the hour. So with that, I'll end. Thank you for the patient hearing. So.
Thank you, Sambit, for your nice presentation, as usual. And we have few minutes time left, so we can take one or two questions from the audiences. But before we start the question, let me share my little experience, because I have looked into our data as far as the COVID-19 infection and the outcome is concerned, and we find that on admission glucose and HbA1c on admission has got a very, very important, and it's closely associated with the outcome of the COVID-19 infection. On admission blood glucose more than 200, and on admission HbA1c more than 7%, either separately or in combination, was found to be associated with significant mortality. We actually checked into mortality. So just to re-emphasize that all our diabetic patients should have very good glycemic control in this period of pandemic. Otherwise, on admission blood glucose or HbA1c, if remains higher, can have devastating consequences. So with this, let me open this talk for any comments.
Can I have a question? Anirban, can I have a question, please?
Please.
Dr. P.S. here.
Yes.
What about mucormycosis? Is it more severe, more common, and more difficult to treat in COVID-19 patients with diabetes?
Yes, sir. I think mucormycosis is not a new disease. It was there beforehand, but with the COVID-19, with the use of steroid, with uncontrolled hyperglycemia, and with other factors, maybe some contaminated oxygen and all. So definitely the prevalence has increased, and difficult to manage in setup of COVID-19. Though mucormycosis is usually seen after maybe 1 to 2 weeks after recovery or discharge from the COVID-19, but many patients are actually RT-PCR positive again with COVID-19. So here the dictum of easy early surgery and early debridement becomes a little bit difficult. And at the same time, the patient may be on steroid because of the pulmonary dysfunction or pulmonary compromise. So definitely all these features lead to more challenges of management of mucormycosis with COVID-19 than without COVID-19.
More challenging and very, very bad outcome if someone develops this mucormycosis along with COVID-19 and with steroid. So if there is no other question, I think we should conclude this session. Thank you, Sambit, again for your excellent delivery as usual.
Very much, Sambit.
And with this, I would like to conclude this session, me and Dr. Sujoy Ghosh, and over to the organizer, Vishnu.
Thank you.
Thank you, sir, for sharing your very valuable insights into such a topical issue these days. We now move on to